Okay, good morning, everyone. So this presentation is going to briefly summarize the process and findings in countries that submitted Equity Accelerator Fund applications to Gavi. So Jhpiego supported 8 countries, including Sierra Leone, Liberia, Burkina Faso, Ghana, DRC, Rwanda, Zambia, and Mozambique to submit their EAF applications. Pakistan and Bangladesh do have some zero-dose activities, but direct support for their application was not provided. So the approach was multi-phased. First, a desk review was conducted triangulating DTP1 coverage from admin data, because in the EAF, the definition of zero dose is any child who has not received DTP1 or Penta1 vaccination. So DTP1 data was correlated with survey data from DHS, MIX, post-campaign coverage surveys, UNIC estimates, and IHME modeling data. This informed the prioritization of the districts where stakeholder engagements would take place based on the prevalence and burden of zero-dose children. Next, a qualitative assessment was administered in these priority districts to get more information on who the zero-dose children and missed communities were and why do they continue to be zero dose. The assessment was administered to the equivalent of provincial and district level EPI managers, vaccinators and EPI supervisors at the health facility level, and community health workers. We acknowledge that a limitation in our approach was we did not have a chance to speak directly to caregivers to understand their barriers to immunization. Finally, a workshop was held at the national level with EPI teams, core and expanded partners, including CSOs, to review the findings from both the desk review analysis and the stakeholder engagements. The second part of the workshop was really dedicated to coming up with the interventions that would directly link the gaps that were found in the previous phases to the zero-dose activities that would be submitted as part of the application. So in that, the purpose, we also were able to answer the key questions in the zero-dose card that Gavi provided on who the zero-dose children are, where they are, how many are they, and why are they zero-dose. So the key findings fall into 6 buckets. First, access. So access, although it is not a negligible issue and it is a major problem in many countries, it is not a problem in every country. So for example, in DRC in 2021, a national household-based coverage survey was done, which found that 75% of zero-dose children lived within 1 kilometer of a health facility, while 90% live within 3 kilometers. Gender, as Anne just mentioned, it is a very important issue, but in some of the countries we did speak with, it is not always an issue. So that's something important to keep in mind. And the other thing that we noticed when we went to countries were countries just assume that gender means that the number of boys and girls who get vaccinated for DTP1 is equal, so do we really have a problem with gender? But it goes much more beyond just the proportion of vaccination. So in some of the interventions that we put into the application included focusing on doing fixed sessions, maybe on the weekends or in the evenings when parents would be able to bring their children. Also taking outreach sessions to the workplace of mothers who bring their children with them either to the farms or the marketplaces. And then also the really key important role of men's involvement in empowering the female caregivers and their families to take decisions on their children's health care so that they would be empowered to take children for vaccination. Regarding data, we know that there are always multiple sources of data when we're trying to estimate zero-dose burden, and this does cause a lot of confusion. But prioritizing districts will also be a dynamic process based on which data source you choose to use. And then we should also keep in mind that there are children who are never included in catchment areas because they have never been introduced into the healthcare system. For continuity of care, there was a recent review of DHS data across countries in Africa that found that 60% of zero-dose mothers actually received antenatal care services. So this kind of indicates a gap in the continuity where mothers were not followed up after delivery to ensure that their children received DTP1 vaccination. So more information is needed to correlate zero-dose with other healthcare interventions. For CSO involvement, there are a lot of CSOs who are working in countries which historically may have worked in other health programs but not immunization. But their deep linkages with the community should be leveraged in order to identify and reach zero-dose populations. For drivers of zero-dose and under-immunized, we found that there are different drivers for each. So while zero-dose may be more based on knowledge gaps and attitudes towards vaccination, under-immunized, or the chances of parents bringing their child back for subsequent doses, was really driven by service delivery challenges. That included the attitudes of healthcare workers, long wait times at the health facilities, and even stock out of vaccine. So in closing, just to say that, again, prioritizing engagements with caregivers is something that we wish we had had time to do, but it has been included in the EAF as one of the key planning activities before the work can kick off. And it is also challenging to develop interventions that are very specific to zero dose, especially for HR training and logistic interventions, because there's always a fear of duplicating these activities in HSS applications which are already receiving funding. More field experience and information is required for optimal engagement with CSOs and male caregivers on how to reach zero-dose populations, and more information on how the zero-dose equity lens can be applied to later ages in life and other healthcare services. So just want to close by thanking the Ministry of Health teams and EPI teams in our countries, our Jhpiego country teams, core and expanded partners, CSOs, and Gavi. Thank you.
Good morning, everyone. So I think yesterday when Dan presented, he actually accused Air France of being responsible for him putting on his running shoes. But I actually understood that if you are given 5 minutes to talk about a piece of work that you have done for like 5 years, the best thing you can do is to put on your running shoes and start running. So let's just start the race. So, sorry, this one is not working. How do I move this slide? Is it okay? The big one? Okay, sorry. Okay, now I don't want to call names, but there are some organizations that will give you $10 and ask you to do a piece of work that will normally cost about $50,000, and that is how we actually started our work. So in 2016, we got some small, a little amount of money from Gavi. Please don't tell your boss that I said this, to explore the reasons for very low immunization coverage in 9 districts, 6 urban districts and 3 rural districts. And the findings were really staggering. So in urban districts, in the city of Yaoundé, we found that about 14% of children who reside within 1 kilometer from a health facility has not received a single dose of any vaccine. And the same also applied to one fishing island, where we found almost 1,000 children who have not received any, almost 1,000 children who have not received any single vaccine. And this one is not only about the DPT, but it's there in that island you can see up to about children who are about 10 years who have not received a single shot of even BCG and so on. So that experience actually taught us that there may be so many opportunities, so many of such communities in Cameroon. And the reality is that with $10, we cannot actually estimate and quantify those insured communities and children in Cameroon that has a surface area of close to 500,000 square kilometers. So we decided to use another approach that other people have used, that is leveraging on GIS technology to triangulate data across different sources to answer the 2 principal questions. Where are these children found, and how many of them are there? And then the next thing is to leverage the WHO tool that Ant spoke about, that is the social and the behavioral and social driver for vaccine uptake, to actually explore the reasons why these children remain unvaccinated. So, and the findings were really kind of interesting in the sense that we realized that over 230,000 children in Cameroon have not received their Penta 1 or DPT 1, and up to about close to about 360,000 children were under immunized. And when you look at the data, you triangulate it with coverage, you actually see that it matches. And then the second, and when we look at when we explore on the reasons why these children are found, we tend to realize that they were heavily concentrated in about 3 different regions. I think we have this region up here, and the center, and also this region. And then again, we wanted to understand the different reasons why they were not vaccinated. And using the WHO framework, we actually identified issues related to thinking and feeling, and most of the time it was actually related to concerns about vaccine safety, sterility, and so on. With regards to social processes, there were a lot of important family and social norms, such as the requirement of getting approval from a community leader or a traditional leader or a religious leader for children to be vaccinated. And then there were also gender issues that were actually emerged as important determinants of vaccination status, spousal approval, particularly the father or the husband will need to approve for a child to be vaccinated. And then there was also this issue about female healthcare workers. In some settings, the best people to deliver shots are female healthcare workers. If you put male healthcare workers there, it's not going to work. And then there was this restriction of movements, particularly in conserved communities like the Muslims, and women are not allowed to go out. And because they're not allowed to go out, the best way to actually reach the children is to do some sort of a home-based vaccination. And then there were other important aspects like motivation, particularly distance was one of them in most of the settings. In some of the settings, particularly the rural settings, because communities will have to families will have to travel long distances on bad roads to get their children vaccinated. And then there was also this issue of waiting time that could be explained by several factors: reluctance to open a multi-dose vial when fewer children are present, and also attitudes of healthcare workers like manipulating their telephones or increased workloads, and so on, and other issues like practical issues, particularly trust in healthcare workers, and so on. So these were actually the findings, and to us it's an eye-opener, and we leverage the findings to actually support the government of Cameroon to apply for funding from Gavi through its full portfolio application. So I just want to conclude to say that we do a lot of important work, and most of the time we do not spend considerable amount of time to actually document the best lessons and practices that could be replicated in other settings. So we are not very good at sharing our lessons and publishing. And this was actually brought to our attention by Bill and Melinda Gates Foundation and also Gavi. Yes, the results are impressive, but we are also interested in understanding the lessons and the methods that you have used. But we said, if you give us $10, how do you expect us to write a manuscript and then also pay $2,000 to get it published? They said, next time, include it in your budget, we're going to pay for it. So we really appreciate you for that initiative, and it's actually a humble call to many of us here. Let's get our work published, because it's only through that we can actually we can actually get ourselves aware of what others are doing, and we can actually adopt those practices and those lessons into our settings, and that could actually make difference. And WHO, you need to talk to journals, let them expand their scope, because at the end, most of them don't actually focus on implementation science, but at the end, what matters is getting vaccines into the arms, and it is not the vaccines themselves or coaching technology that does. It is the tactics and the strategies that get vaccines get vaccines into the arms, and it is that aspect that saves lives, not the vaccines themselves. And for that, I thank you for your kind attention, and I hope I did my best to stay within time.
All right, good morning, everyone. It is a pleasure to be here with you all today. I'm presenting on behalf of the Gavi Zero Dose Learning Hub. And for those who may be unfamiliar, one of the kind of broad, high-level objectives of the Zero Dose Learning Hub, or the ZDLH as we call it, is to address immunization equity by identifying and reaching under-immunized and zero-dose children. So in pursuit of that very large objective, over the last several months, my colleagues and I have been conducting 4 immunization landscape assessments. So one for each of the 4 ZDLH Country Learning Hub countries, which are Mali, Bangladesh, Uganda, and Nigeria. And these landscapes are intended to help us better understand the unique immunization context in each of those countries, to identify opportunities for intervention to reduce the prevalence of zero-dose and under-immunized children, and finally to help inform zero-dose research and programming efforts at the country level. So in short, we're kind of looking at all of the available resources and research in these 4 countries that help us better understand the country-level zero-dose context. We're synthesizing that evidence and then identifying areas where there may be research gaps or where we may be able to direct programming efforts in the future. So in order to pull evidence for these landscapes, we conducted literature reviews and secondary data analyses. For the literature reviews, we searched basically anything we could get our hands on. So that included peer-reviewed literature, as well as gray literature, resources from ministry and partner websites, government resources, stakeholder websites, existing Gavi reviews and analyses, just anything that we could use to get a better sense of the immunization context. And in order to estimate vaccination coverage, we conducted secondary data analyses of data from a number of sources that included the DHS, WUNIC data, and IHME data as well. And in our search for evidence, there were a number of domains that were of particular interest. We were, of course, interested in immunization coverage. So what is the prevalence of zero-dose children in each of these countries? We were also interested in immunization equity. So how equitable is immunization coverage across various sociodemographic and environmental contexts? Human resources for health, so what are the cadres that support immunization delivery and what research has been conducted regarding the adequacy of that support? Immunization financing, national policies related to immunization, and finally of the health system structure as a whole. So based on the evidence that we collected, we identified a few cross-country findings as well as a few research gaps that represent potential areas for further inquiry. And this is going to sound extremely obvious, but I think it's still important to acknowledge that the immunization context is so vastly different in each of these 4 countries. And even within the countries themselves, from region to region, from district to district, you're going to encounter different barriers to immunization. The predictors of zero-dose status are going to differ in those areas as well. And so it's helpful to kind of pull out learnings from the past and how children were reached successfully to help guide programming moving forward. So to start, as I kind of already mentioned, there are inequities in immunization coverage across various geographic, socioeconomic, ethnic groups, with predictors of zero-dose status varying widely across the 4 countries. The next area is related to data quality assessments. So as I'm sure we all know, good quality data is really critical to identifying where zero-dose children are located. And the one thing that we found is that there really aren't many assessments looking into the quality, so the completeness, the timeliness, the accuracy of immunization data, particularly at the lower levels of the health system, so really at the service delivery level. And there also hasn't been much research looking into the barriers to immunization data reporting. So what are some of the challenges that immunization staff face in collecting and submitting data? And just for example, we know that in some contexts, paper-based data is used, and we don't fully understand how that paper data is managed, how that data is collected, and how it affects the overall quality of immunization data. So these are just all areas that can be explored further. Another major gap, and this is something we could spend hours talking about and continuing to break down. Fortunately, we don't have the time. But there are a lack of research studies, both qualitative and quantitative, looking at immunization coverage across different environmental and sociodemographic contexts. So just to name a few, across ethnic minorities, refugees, and conflict and climate change affected areas. And we don't always know, or we don't have reliable coverage data for those groups, but we also don't have very much qualitative data looking into what are the barriers to immunization for those groups, as well as the drivers for immunization. And in our look at national policies related to immunization, we found that while each country has strategies, targeting vaccination coverage. So, every country does have very, kind of explicit policies and strategies targeting vaccination. They don't always, use the language zero-dose children in those strategies. But either way, it still signals a strong commitment from each of these countries to vaccination increases. And we know that the active involvement of country governments and stakeholders can really drive vaccination success. Finally, we found that there is limited data looking into the adequacy of staffing for human resources that support immunization services, especially in remote areas. So we usually know the number of staff and the ratio of staff to people, but we don't always know if those numbers are adequate and what the challenges that the immunization workforce faces. This kind of information can help to inform human resource programming as well as advocacy efforts, and it can also kind of help us to improve decision-making about how to distribute and train staff. So that is this work really in a nutshell. I have the QR code here in case you would like to look at the country landscapes. Mali and Bangladesh are currently up on the website. Nigeria and Uganda will be posted very soon, most likely within the next week. So thank you all very much for your time.
Thank you. Thank you. That was a fascinating presentation from everybody here. Another round of applause for our speakers. Great. We do have two people at the back there to pass around mics if you have questions for our speakers. Basically, would appreciate it if you introduced yourself and directed your question at specific speakers on the panel here, and they'll be happy to answer. So please raise your hand if you'd like to ask any questions. In the meantime, I will maybe start us off with a few initial questions, if you don't mind. There are so many, but I'll also keep some for the audience. But maybe Anne, I guess the first question that comes up when we talk about gender is, are we doing enough to adapt programs, right, to be more gender sensitive? And what can we do? What more can we do?
Definitely not. Definitely not. I think this area of assessing gender barriers for equity is just like awakening, more or less. There's a very strong focus by all the IA 2030 partners, UNICEF, Bill and Melinda Gates, Gavi, WHO, and all different partners around. This is an upscaling issue that we all need to pay attention to. I don't think we do enough. And I do not, and you heard me say, I don't think that we are even literate. We're really starting to kind of crawl up of our crib now and get going. We need to educate ourselves, for a starter. But from there, it's much, much more. I think that maybe the gender analysis of barriers and so on may be starting. But as I mentioned as well, in the initial NIS and the different Gavi proposals that are around, there's not enough movement on the implementation of actually adapting services into a more gender sensitive or a gender transformative way of working. So action, 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 starting with ourselves, getting more knowledgeable, and then actually having these conversations with all our different partners, and particularly encouraging country level staff of all kinds to take the courses, become aware, and act on it. Thank you.
We have someone with a question.
Hello, Stefano Malvolti from MMGH Consulting. I have a question on zero-dose children. We did some work on the topic, and I noted, the interesting approach to try to improve the quality of the denominators by adding, for instance, to the existing listed children in the registries with children that has been reached, mother that has been reached to the ANC services. And I was wondering whether there has been any other attempt to extend to other programs like NTDs, vitamin A distribution or others, because that issue of the total denominator is the issue, right? We don't know which are those children. So looking at any other source of information is critical. And the ANC was very nicely noted. I was wondering whether there is any other experience from the people here in the studies in other type of health service. Thank you very much.
Somebody want to have a stab? Meg?
Yeah, thanks. That's a really good question. And I think it really speaks to how important integration is. And as it's been said before, even yesterday, that immunization cannot work as a silo. And so we really need to capitalize on the other opportunities. So one of the things that we've also been thinking about is the importance of now that the malaria vaccine is being introduced and is already introduced in some countries, because the idea is that parents recognize how much malaria really affects, a child's life and their own life. And so is it possible, but that kind of knowledge or that kind of information may not be very clear for other vaccines. So when parents are bringing children for malaria vaccination, it would also be a great opportunity to not only get them into the system, but also vaccinated for other diseases.
Thank you very much. I think this is a very important question, and I think my suggestion will be to really figure out how to establish some sort of a partnership with some other stakeholders, particularly organizations like UNFPA and also UNICEF, particularly those organizations that are concerned with the rights of children. And I say this because it's particularly important for developing countries, particularly in Africa, where the population, it's so hard to get the exact population, and where population gets inflated for political reasons. So if there is some sort of a global agenda, at least bringing the key stakeholders that matter to talk to the politicians and setting up systems that could actually enable countries to get accurate population data for their countries. I think that's going to help. And then also figuring out how to improve on bed registration, ensuring that each child has like a birth certificate or other form of identification, particularly in all the settings, including mixed settings. I think much work has to be done, but I think we really need to approach it from a global perspective and then see how we can leverage global forces to drive a global agenda that will actually enable countries to uptake and integrate it into their political or government systems. Otherwise, it becomes very difficult to get that done in developing countries, particularly sub-Saharan Africa.
Thank you very much to all the panelists. That was really great, important session. My question is to Anne, sort of building on what you said at the end of the last question, the call to action, and it's about those courses you put up. Thank you so much for that. I have a series of questions about that. One, are those courses targeted for health workers at all levels of the system? Are they mostly for implementing partners? Once the course is taken, because definitely the first step is to educate ourselves. Is the course designed just for awareness, or does it sort of lead to very clear actions? I'm trying to understand two parts to the question. Is it accessible and designed for health workers at lower levels of the system, or is it mostly targeting sort of design decision makers? The second thing is, what we have realized when we provide these courses is health workers are motivated if there's a certificate or something at the end of it, but also if there's a way to practically apply it. So that's the second part of my question. For us who are in the room, what is our call to action? Is it to get health workers, and who is it that we should be sharing these courses with, and what else could we be doing sort of to help spread that that awareness and that action? Thank you.
Thank you for that question. So the two courses are mainly for immunization stakeholders, at national, international level. So it's educating ourselves before we can do it's not at lower level health facility. The courses are, really hands-on. They build on, the knowledge that is accumulating about how you, first of all, look at disaggregated data, how you make a gender analysis. It's about, the awareness of what are the types of barriers that we need to kind of look for. They are going through the tools of, how to do this gender analysis and what indicators would make sense to kind of follow to see, what you measure, you get your eyes on and you actually do something about. So I think these courses were deliberately kind of an initial step for making immunization stakeholders at national and international level much more literate. It's the first step, and it's not enough. It's definitely not enough. So I think taking it to the next level of health care workers being aware and finding the solutions themselves. We do have another project together with the Sabin Institute and many others, the MGF. We are working on a IA 2030 fellowship course, which looks at all of IA 2030 different, and the participants getting more, taking this course are encouraged to do their own kind of project. And then a few of them are selected to be supported to implement those. That's where it comes to really kind of the juice, where you have the local owners at country level, healthcare workers being able to implement in their own context. But I hope that helped you.
Hi. Hi, I think I'm next. Wonderful presentation. Thank you, everyone. I'm Lisa Oot from JSI. My question is for Meg and then also Elena. The data point that you provided, that 60% of zero-dose mothers received ANC, I was curious if you'd done any qualitative research understanding how those ANC visits and the service experience that they may have received at those visits, how that transformed to their desire to go back to the health facility for vaccination of their children. Because I think it's a really missed opportunity to understand how previous engagement with the health system really dictates how our communities seek vaccination services. And then similar for Elena, if this was something that you looked at in your literature search around issues related to service experience, and if previous experience with ANC or postpartum care or pregnancy care, and how we can do better about triangulating that data. Thanks.
Yeah, thank you for that question. So unfortunately, again, we weren't able to speak directly to mothers during the qualitative assessments that we did. Otherwise, I think this would have been an excellent question to ask, because we do agree that the experience they have before will definitely dictate what happens after the child is born. But we hope that in the future, if we do have chances to speak directly to caregivers at the household level, this would be something we prioritize asking.
Yeah, likewise. Thank you, Lisa, for that question. I can add that to the ever-growing list of things that we have yet to explore. I can't say that it did come up in the research that we looked at, unfortunately.
Can we hear me? Good morning. My name is Dorothy Lee from Ganeshade. So thank you very much for the impressive presentation and very inspiring. We have been supporting different countries developing EIF application and FPP. I think that one critical aspect of this process was to understand to which extent the countries can access to knowledge about, strategies, pro-equity strategy to reach the zero dose. Currently, we have conducted this exercise of analyzing where are they, who are there, how many are there, and why they are currently, we have this zero dose at country level. But the main point is that Gavi requirements is to introduce new approaches, innovation to reach these children who are currently left behind. Unfortunately, we don't have access to these approaches. So working with different countries, we were capable to benchmark the existing strategy because of conflict area, because of ethnic minority groups, because these kind of things. I think that maybe, I don't know who could support this approach, but really enable the access of the countries to pro-equity strategies, interventions that works from one country to another country. I think this is key. And I think that our colleague Clovis from Cameroon explained about the needs for transforming results from, assessments or even experimenting, intervention into concrete learning products. Currently, we don't have really this process. So I think that was one question. How can we together bring to the country innovations or approaches already experimented from one country to another country who can really support the reach of the zero dose? So that was my first question. The second question is much more related to the question of the gender-related obstacles to immunization equity and coverage and immunization coverage. I think that, working with country, they were at the first reaction at country level, with in-country partners and government representatives. What is about these gender things? We're thinking, okay, so this is the children, the boys and the girls, immunization coverage. So the knowledge was so low, really no, we say it's a weakness. I think we should really accelerate the process of, to not educating, I would say, but really own the process of designing or co-designing pro-equity intervention to reach the zero dose with this gender lens and with the community itself. And currently, this is not the case, so I don't know how we can, I don't have any solution. I'm just putting on the table that this is something that maybe we need to get the forces for making this happen. Thank you.
Thank you very much. Let me just begin with the gender aspect and the equity accelerator application. I think for Cameroon, we did have a robust application. And when we got comments from Gavi, I think the area that was highlighted that lacks sufficient details or approaches is actually the area of gender. And I'm really tempted to think that perhaps Anne was one of the person who reviewed that application and made those recommendations. But I think it's an important issue, and I think moving forward, countries will really need to take into the gender aspects seriously into their application, because these things, they have a way of impacting service delivery. So if you have a setting that does not accept male community healthcare workers, it makes no sense actually investing in sending male community healthcare workers there. So those are some of the things that we are learning from the field. And then the second question with regards to the approaches that could be used to reach zero dose children. I think from my experience, we don't actually need sophisticated innovations. I think that is my experience, particularly in some of the results we have had in Cameroon. So if you take, for example, one of the fishing islands, Manuka, the government and also WHO and other organizations will tell you that at least to deliver vaccines to these communities, you need an engine boat to transport the healthcare workers and other people. But the reality is that running and maintaining that engine boat is prohibitive. So you spend about $7,000 to buy that engine boat, and then you have to buy fuel and pay the operators and so on. At the end, it's not sustainable. So one of the things we learned is, let's figure out how does the basic commodities reach those communities. So what means of transportations do they use? And it's very easy. In the context of Cameroon, we found out that you just require about $5 to get vaccines from a central store to a community. Right, so really like figuring out how communities go about their day-to-day operations, and then thinking about how to use those approaches, those approaches and those opportunities to deliver the health products to the last mile. I think that can make a difference. And then on the issues of acceptance and uptake, there are also lessons we could learn that do not really require significant innovations. For instance, how do politicians get votes? How do they get voted in those communities? What strategies do they use? They are not sophisticated, they are not complicated strategies. So it's left to us to study those things and then contextualize it in the context of immunization. So I think we currently have some funding with from some funding from Gavi, and in the project we are gonna develop about 5 different models. What are like the appropriate models, cost-effective models to reach sustainably reach children within nomadic communities, enclaved zones and islands, and also conflict settings. So I think after the research, we're gonna have some interesting insight that we're gonna share, which we think that they are not gonna be very resource intensive, but at the same time practical, feasible, easy to do, and replicate in other settings. Thank you.
And please come in. Yeah.
Yeah, may I point to 2 resources that respond to your question? One on the cross-country learning, which is probably the most powerful, right? The peer-to-peer learning. So the Gavi Alliance have put together a community of practice for zero dose. And I will, if I manage to get onto the TechNet chat that we have, I'm going to send the link. Otherwise, I'll ask Dan to help me. So in this community of practice, there have been many conversations, including between countries, of sharing lessons learned of how to reach the zero-dose children, including lectures on practical examples and thematic areas, which are all accessible as well. You need to, I think, log in and be part of the community, but honestly, it's a very good resource. Second resource is on TechNet, actually. And we looked across in WHO and said, do we need to do more guidance here? And then we looked at all the resources and we said, maybe we just have to kind of structure the access to the different zero-dose guidance that is out there. And so on TechNet, there is kind of a portal, which we should also put on the chat here, where you can, you ask a question and then you can have tailored, these are the people and the resources that you actually, not the people, but the resources that you need to look at to actually access and work better into the zero-dose work. So I think those 2 resources respond a little bit to what you were asking.
Ding. Oh. Okay, go ahead.
Hi, good morning. Thank you all for the fantastic presentations. My name is Emily Nicholson. I'm the digital health specialist for UNICEF down here in Latin America. I'm particularly interested in the gender digital divide and how barriers to women's access to and comfort with technology affects immunization, both for female frontline health workers who are using digital tools with much more frequency, and for mothers and caregivers and how they're able to access information via digital platforms around immunization and demand generation. So I'm wondering maybe for you in particular, if that's an area that WHO is interested in studying and exploring further. Thank you.
It was more a comment than a question, right? I would say yes, definitely, but you are the expert more than me. I think you're right, and it needs to be explored. If this is one of the barriers within the gender access, I think what I presented was what we all know in public health, right? The access to information is one of the basics, really one of the basics. Having female health promotion clubs or information sharing in a safe space, etc., important. But also more modern digital tools of being able to transmit and share more maybe rapidly health messages, which is one of the tools. And I think I agree with you. Thank you.
Good morning. My name is Modibo Diko from the Balanzan Institute in Ouagadougou, Burkina Faso. Thank you all for your presentation. I really like the fact that you all propose solutions. But those who did studies on equity issues know that the more the mothers are educated, the higher the coverage of their kids, immunization coverage. But I didn't see in any of your solutions linking with the schools in the places you are doing your project, or linking with the education system in general, so that you pull your hands and you can work together to address this issue of inequity linked to gender. Let me ask Meg Sreevatsava to start firing.
Thank you for that. And you're right, that was not included as one of the strategies for our interventions. But I think one of the things that we have also discussed in the past with the countries has also been this idea of disseminating information on vaccination through siblings who are also attending schools when that is the safe and kind of accepted practice. So if there's chances to educate middle school or high school children who could then take that information back to their parents on the importance of maybe vaccinating younger siblings or other family members who are eligible for those vaccines. So that's just one strategy we have thought about, but linking up with the education system is also something to consider in the future.
But I think one of the challenges that we see, particularly in mixed communities, is that there are no educational facilities, right? So people there typically do not go to school, and I think it's really a call for action to see how different partners can join forces to ensure that those basic social services are put in place in such communities. So I think at country level is gonna be a multi-sectorial approach is gonna work, but we need to figure out how to get that done.
Thank you. My name is Chizoba Wonodi from Johns Hopkins International Vaccine Access Center. Thank you so much for the presentations. And as I was listening to the presentations, I thought about some of the reasons that healthcare workers over time have mentioned as reasons why they are not able to vaccinate children, which is simple, either funds to do outreaches, funds to go collect vaccines, simple logistical issues like that. And within the zero dose IRMA framework, there is a piece around advocacy, which is advocating for resources to implement zero dose pro-equity interventions. I haven't heard anything from these presentations around innovations in advocacy in ensuring that there is resources, domestic resources, to implement those simple things, not the esoteric ones, the simple things that will get vaccines to children. I don't know if you guys have any ideas of how we can solve the perennial problem of health workers not having simple funds to do outreaches that will get the zero dose children vaccinated. Thank you.
So if I can comment, I think it's actually not based on experience or research, but I think I see an opportunity because I know Gavi has set aside over 500 million US dollars to actually stimulate the dialogue and development of strategies to reach zero dose children. And I think some of the components of the strategy, or some areas where the part of the funding is going to go to, is really how to deliver, in short, how they provide the necessary funds to get vaccines and immunization supplies to those mixed communities. So that is it's a good thing. for the start, but I think we also need to think about the long term. How do we sustain that? And that is really where we need to start thinking about how to build advocacy and collaborate with the government to ensure that national strategies for reaching zero dose children are developed, a budget line is created for that, and so on. So I think it's really an important question that we need to take forward to see how governments can actually build on this on this significant investment from Gavi to sustain reaching zero dose in the long run.
I think we have time for one last question.
And I'm the last one.
Yeah, there we go.
Good morning. My name is Brigu Kapure. I'm from UNICEF. Is this working? Yes. Thank you, Anne, for bringing gender on the plenary session. This is really important where we talk about gender into immunization. But on the country perspectives, when we look into it and when we try to apply the gender transformative lens on immunization, sometimes what happens is the immunization program manager comes back and says that, but these are social, cultural things that needs to change. How do I as an immunization take it across? And I think this debate always ends over there where I don't see a very direct correlation of me changing their social and cultural pieces across. This needs to be addressed with very specific tools. And I am really happy to see the linkages and the links provided. But we need to bring this that this is not a side business. This is the main business. This needs to be part of the DNA of immunization program. And this could be immunization as an entry point for bigger primary health care where we are changing the gender landscape, because what we try to change over here will also have a direct impact on the entire primary healthcare and the primary healthcare systems. So I think tools that are very clearly guiding to the immunization program to address this is a very critical need, because otherwise the discussion goes on the table but then gets stopped over there because I don't have a very clear answer of what do you want me to do inside that.
Wow, that's a big question. How do we actually break gender powers? I mean, long term. And I do agree with you. It's just so much larger than what we can do. I think we need to focus on what we can do, right? And take steps to actually prove the difference. So doing the gender analysis, changing services little by little, planning, doing, learning, sharing, and just start small, so to say, right? And then maybe also, you know, as at the global level, et cetera, really proving and showing those lessons learned that we discussed yesterday about how it really makes a difference. And I fully agree with you. It's beyond immunization. It's primary healthcare. It's health services. It's also kind of at the political level, you know, the laws and at a social construct much larger. And change perceptions, right? And we're on a long journey, but unless we start, we know we will get nowhere. I think the polio program started early because they really saw how the difference is. I mean, starting small, just employing healthcare workers that are female, that are accepted by the communities in a way that they can come into health households, do the vaccination in place, etc. So I stepwise, but never giving up.
Thank you. I know that there are a lot more questions, but I believe we do need to wrap up. So let me maybe open it up to Elena to deliver a closing statement. I think one thing you want people to walk away from the room with on your presentation.
Sure. So I'm well aware that my presentation maybe asked more questions than it answered. But I think that was really, for me, the takeaway of the work that we did was that there's just so much more to explore, so much that we really haven't considered, so many gaps. And it goes, kind of deeper than just the country level, regionally, just small communities. There's so much more. That is my thing that I would like everyone to walk away from here with, is that we have not really even scratched the surface of the research that we can do.
Thank you, Ashvin. So for me, two things. I think the first is we really need to be fast and proactive. So the concept of leaving no one behind was actually ratified and adopted in 2015. Why did we need about 7 years to make it a thematic topic for debate? Why that time lag? So I think we need to answer the question and start thinking ahead. How do we take a serious concept? How do we act on serious concept immediately? And then the second takeaway is from the question that our colleague from John Hopkins asked, and this is actually like a special appeal to Gavi. How do we connect the concept of sustainability into EAF applications? In short, countries would definitely need to spell out clearly how they are going to sustain the investment, and then Gavi and other organizations like WHO, UNICEF, CHA will need to start engaging countries on how to sustain that investment. Otherwise, the $500 million is gonna it's not gonna create significant impact in the long run. Over.
Thanks. Yeah, so I think what I would like the main takeaway to be is that I think for many years we have known the answers to the questions who, how many, where, and why. And I don't think any amount of analysis or doing it in different countries is going to change the information that we have on that. But I think what's really going to matter now is that what are we going to do with this information? And this is where the Equity Accelerator Fund, these interventions that we have proposed across several countries, once we start implementing them, getting information on what is working, what isn't working, how to tweak these interventions as we continue to implement them in the field, that's really what's going to provide a lot of information and kind of be the game changer to start reaching these communities. Thank you.
Educate yourself on gender matters and do it with curiosity because there is a huge potential here that we've not explored enough.
Thank you. That was very quick and concise. Thank you, everybody.